I am Alpha Phi Alpha Surgeon General, Dr. Jeffrey Sterling. This blog is on disparities in HIV. I'll briefly explain the differences that exist in HIV between different segments of the population, then offer you tips on how to reduce those disparities. This information is largely provided from the U.S. Centers for Disease Control and Prevention. Let's get started. Despite advances in the prevention and treatment of HIV, human immunodeficiency virus, there are certain communities that remain disproportionately affected by the disease. Many of these factors, such as poverty and race, are linked and leave entire communities vulnerable to infection. Not only are these groups more likely to get HIV, but they are less likely to be diagnosed or remain under medical care. Today, around 1.2 million people are living with HIV in the United States, with over 36,800 new infections occurring every year. The communities at greatest risk include men who have sex with men, Black people and other persons of color, women, and injecting drug users. Let's discuss some of the factors that drive HIV infection rates in these and other communities. Let's talk about poverty. Poverty influences HIV transmission rates as much as it does any other communicable disease. Unless there is coordinated investment in public health education, outreach, testing, treatment, and follow-up, an infection like HIV can spread like wildfire through vulnerable communities. While richer communities have access to many facilities, poorer communities often do not. There is perhaps no better illustration of this than the breakdown of the US HIV infection rate by income. According to a study from the Centers for Disease Control and Prevention, no less than 76% of people living with HIV in the United States have a household income of less than $20,000 annually. Of these, 39% are unemployed, while 18% report recent homelessness. Living in a poor community can also leave residents doubting whether any governmental institution, including public clinics and hospitals, has their best interests at heart. Poverty and HIV are inextricably linked, leaving those without access to quality healthcare, housing security, or employment at greater risk of infection. Healthcare access is also an important factor to consider. Today, a person newly diagnosed with HIV can live a normal to near normal life expectancy if treated early. This not only requires the daily use of antiretroviral drugs, but also consistent medical care to ensure that prescriptions are filled and the infection is properly managed. This is a bigger challenge than some might expect. The Affordable Care Act, also known as the ACA, has gone a long way toward ensuring health coverage to people living with HIV. Prior to the enactment of ACA in 2010, around 30% of people with HIV were uninsured. Today, that has narrowed to around 11% uninsured. Even so, around 132,000 people living with HIV in the US still have no health insurance of any sort, whether private, governmental, or work-sponsored plans. Even if the uninsured are able to access treatment through patient assistance programs and other means, they are 24% less likely to achieve an undetectable viral load, which is the ultimate goal of treatment, than people who have insurance. In some states, the option for coverage are limited for low-income families. The recent fight to block Medicaid expansion is one such example. The expansion was meant to increase healthcare access to the poorest Americans, but the expansion was rejected in 12 US states, and the fallout has widely been felt in communities at risk of HIV infections. In the 12 states that rejected Medicaid expansion, 19.4% of residents living with HIV remain uninsured, compared to 5% in those living in states that opted for expansion. By contrast, in the states that adopted expansion, HIV testing rates have increased by 13.9%. Now let's look at race as a factor. According to the Census Bureau, the poverty rate amongst Black people currently stands at 18.8% compared to 7.3% for whites. For Latinx people, the poverty rate is 15.7%. These differences alone contribute to higher HIV infection rates in communities of color as a social determinant of health. In 2019, the percentage of new HIV infections broke down as follows. 42% occurred in Blacks, 29% occurred in Latinx populations, 25% occurred in whites, 2% occurred in mixed race populations, 2% in Asians, and 1% in Native Americans. Overall, people who are Black and Latinx are more likely to live in areas of racial segregation. These areas often experience higher levels of poverty, crime, drug use, and sexually transmitted diseases, all of which drive HIV infection rates. However, poverty alone doesn't explain the disparities. Medical mistrust, fueled by failures of the healthcare system, has led some in the Black community, Black men especially, to adopt negative attitudes about condoms or embrace denialism that keeps them from seeking testing or treatment. Moreover, the cultural stigma of having HIV can be especially impactful in marginalized communities where the risk of discrimination is real and the avenues for recourse may be few. Studies have shown that cultural biases like stigma and homophobia play a central role in the disproportionately high rate of infections in Black communities especially. Let's talk about racial disparities in treatment. According to the CDC, only 48% of Blacks with HIV remain in care after their diagnoses, while only half are able to achieve an undetectable viral load. Those figures are significantly lower than what is seen in either white or Latinx communities. Among men who have sex with men, they account for the lion's share of HIV infections in the United States. Although men who have sex with men represent only between 2 and 7% of the US population, no less than 65% of all new infections are attributable to male-to-male sexual contact, according to the CDC. These men are at risk at HIV for many reasons. Anal sex is an efficient means of transmission since rectal tissues are vulnerable to rupture, allowing the virus easy access into the body. Scientists estimate that the risk of infection from unprotected anal sex is in fact 18 times greater than the risk of unprotected vaginal sex. But beyond the physiological risk, men who have sex with men are commonly faced with homophobia, stigma, and other biases that only amplify their vulnerability to infection. Because of this, some of them will evade testing out of the fear that a positive diagnosis will force them to out their sexuality to family, friends, and coworkers. The fear of abandonment, discrimination, and even violence will force others to hide their HIV status and manage their disease in secret. Faced with isolation and a lack of social support, some will even turn to alcohol and drugs to deal with anxiety and depression, behaviors that increase sexual risk-taking and promote the spread of infection. This risk is further compounded when other issues like race and poverty are involved. According to the CDC, Black men who have sex with men have a 50% risk of getting HIV during their lifetime. The intersecting factors of race, stigma, homophobia, and poverty account for why Black men who have sex with men account for 26% of all new HIV infections in the United States. Women, and most notably women of color, are also disproportionately affected by HIV compared to their heterosexual male counterparts. The increased risk is due in large part to the vagina itself, which has a larger surface area of porous tissues than the male penis. Because of this, the risk of HIV from male to female is roughly double that from female to male. But other factors can contribute, including traditional gender roles that dictate who in the relationship is in charge. The economic dependence on a male partner and fear of abandonment can further decrease a woman's sense of sexual autonomy. Intimate partner violence, including rape, is also a major driver for HIV infections. Studies have shown that women in violent relationships are 4 times greater at risk for contracting a sexually transmitted infection, including HIV, than women in non-violent relationships. Among Black women in particular, these and other issues have led to disproportionately high rates of HIV, and not only compared to Black heterosexual males, but to other groups of women as well. In fact, a Black woman's lifetime risk of HIV is 15 times greater than that of a white woman and 5 times higher than that of a Latinx woman. Black women account for the lion's share of HIV infections among women in the US. In the latest CDC surveillance, 3,758 Black women were newly infected with HIV compared to only 1,739 Black heterosexual men and 956 white women. Injecting drug use is the hitting HIV epidemic. Although injecting drug users represent a smaller proportion of new HIV infections, they are individually at higher risk due to the blood-borne transmission of the virus through shared needles and syringes. Injecting drug users also tend to do less well when forced to manage between an addiction and HIV. In many cases, this can lead to a gap in treatment. By contrast, people on addiction treatment, such as methadone, are able to stick to HIV therapy better than those who actively shoot drugs. Another factor stifling HIV treatment and care is the social stigmatization that injecting drug users commonly face. Many users are in fear of arrest or legal action. In some communities, healthcare services can be unfriendly or unresponsive to the needs of injecting drug users. This includes the absence of clean needle exchanges designed to prevent the sharing of needles. The public perception about injecting drug use has complicated efforts to identify and reach users in an effective way. Contrary to what many people believe, injecting drug use is higher amongst whites than Blacks, with roughly 25% of users having a college degree or higher. And while 75% of injecting drug users live at or below the federal poverty level, there are also upper income earners who inject drugs. This includes people who inject methamphetamine, the practice of which is driving HIV rates amongst men who have sex with men. Because injecting drug use has become so widespread and has touched so many different communities, both urban and rural, public officials have begun to localize their response. Even so, gaps in healthcare resources and the lack of an appropriate government response have led to outbreaks in HIV. One such outbreak occurred in 2015 when 215 people in Scott County, Indiana were affected due to the opioid drug OxyContin. It was only after the outbreak that the ban on clean needle exchanges was lifted. According to the CDC, 28% of injecting drug users who sought treatment for an opioid addiction were unable to obtain the medicines to do so. HIV disproportionately affects certain communities. These include those who live in poverty, people who are uninsured, Blacks, men who have sex with men, women, especially women of color, and injecting drug users. Today, more tools than ever are available to prevent HIV. Let's talk about strategies that you can use to prevent the spread of HIV. Abstinence is really the only 100% solution. A variant of abstinence that I'd like for you to consider is simply being abstinent certainly prior to testing you and your partner's HIV status. If you're going to be sexually active, there's just no need to do the rush. Go get tested, make sure you're safe, and continue on. Never sharing needles. Even better, never deciding to inject drugs. But remember, this is a blood-borne pathogen, and sharing needles is a very efficient way to transmit HIV. You need to learn to use male and female condoms the right way every time you have sex. Use water-based or silicone-based lubricants to help prevent condoms from breaking or slipping during sex. Take advantage of HIV prevention medicines such as pre-exposure prophylaxis, also known as PrEP, and post-exposure prophylaxis, known as PEP or PEP. If you have HIV, there are many actions you can take to prevent transmitting HIV to others. These include taking HIV medicine called antiretroviral therapy or ART. This treatment can reduce the amount of HIV in the blood so low that a test may no longer be able to detect it. Most people using ART can get the virus under control within 6 months. Without the means to redress the historic lack of access to quality healthcare, or cultural issues like stigma, homophobia, and systemic racism, infections like HIV can rapidly spread through our communities. Do what is within your power to stop the spread. Look for additional content on Sphinx TV to assist in your health journey. I'm Alpha Phi Alpha Surgeon General, Dr. Jeffrey Sterling. Thank you for watching.